Okay. So thank you for joining this webinar hosted by PHE's National Mental Health Intelligence Network on our recently published report on severe mental illness and physical health inequalities. Before we begin, I'll give you a quick overview of what we're going to cover in this webinar. We'll start off with Cam Lugton, Programme Lead for the National Mental Health Dementia Neurology Intelligence Network, giving an introduction to the National Mental Health Intelligence Network and this webinar. Will then be followed by Gabi Price, who is Head of Mental Health Intelligence for the network. She's going to present on the key findings on the physical health inequalities people with SMI face and how you can apply the methodology from the report to your local area data. And then we'll finish off with a presentation by Andy Bell, who's Deputy Chief Executive for the Centre for Mental Health, and Hannah Lewis, Senior Policy and Practice Officer for Rethink Mental Illness. And they'll be giving us an overview of the Equally Well UK initiative. I'll now hand over to Cam.
Thank you, Simran. I'd like to spend 2 minutes introducing the Mental Health Intelligence Network, because there will be some people listening to this webinar that don't know our work in detail. And then I'd like to take 2 minutes to introduce this report and this particular topic. So if we just move to the next slide. The National Mental Health Intelligence Network is hosted by Public Health England, and it takes a population-based approach to mental health intelligence, but it aims to provide intelligence for the whole system. We think there are basically 4 elements to what we do, and I'd like to talk about those 4 elements, but also talk about them in relation to this particular report that we're discussing today. So first of all, we think we have a role around dataset investigation. And in this particular case, we looked at a large sample of record level primary care data to try and understand some of the detail on the physical health experience of people with severe mental illness. After doing dataset investigation, we then move on to the development of reports or profiles. In this case, it's the development of a report, and what we aim to do is enable use of intelligence on this particular topic. We believe we have a role around engagement and dissemination. This is basically the purpose of this is there's little point in developing intelligence products unless people are able to use them and they're able to help make change happen at a local level. So this webinar is that dissemination exercise in practice, and we hope what we provide today means that the report that we're discussing helps local people focus on the physical health of people with severe mental illness. And then finally, we believe we have a role around the coordinated and effective use of data across partners. Because we take a public health approach, where we look at the whole pathway, it gives us an opportunity to work with a wide range of partners, and it means that the network is well positioned to try and have that coordinated role, which means that we can do things efficiently and effectively. And the whole purpose of what we do is to support and enable local intelligence-based decision making. Next slide, please. If you are interested in our products and want to take a look at what we do, then these 2 websites that you see on the slide at the moment will enable you to access pretty much everything we do. So the first one takes you to the Fingertips site, and that will take you to a suite of 7 topic-specific mental health profiles. So that will take a whole range of data collected into one place to enable you to profile your local area and benchmark that area against geographical or statistical neighbours. We also have a site on the gov.uk web space, which will mean that's the place for you to access all of our mental health based reports and also our data catalogues. And what we aim to do with this is to provide relatively short plain English reports that we hope really help and enable people to apply intelligence locally. Next slide, please. So that's generally about the Mental Health Intelligence Network, but now I want to move on to the focus of today, and that is reducing premature mortality in the population with mental health problems. Can we move on to the next slide? And that work, from a policy perspective, is very much driven by the 5-year forward view for mental health. So the slide you see in front of you at the moment lists just 2 of the recommendations within that document. Recommendation 20, which has a Public Health England lead, which focuses on this population group, looking at people with greater risk, people with severe mental illness who are at greater risk of poor physical health, and ensuring that they have access to prevention and screening programs. And that is aligned with recommendation 22, which asks for the same population group to have access to evidence-based physical health checks and interventions. So if you view those 2 recommendations together, in effect what they're asking us to do is look at the care pathway and look at the care pathways for the physical health of people with severe mental illness and make sure it works for that population group. So that's the aim behind this report and this webinar today. Next slide, please. But it's still important to remind ourselves of why that is. Why are we focusing on this group, and what do we understand about this group, and why are we trying to address this particularly stark inequality? So the bold statement at the top of this slide says people with severe mental illness in England die on average 15 to 20 years earlier than the general population. Obviously that's a very stark finding, and a great deal of that early mortality is avoidable. But what we need to do is understand it and focus in on how and where we should address it. So the graph that you see below the heading is a standardized mortality ratio. And the way standardized mortality ratios, or SMRs, work is it's generally a comparison to 100, where you will see a score of greater than 100 indicating worse health, and a score of less than 100 indicating better health. So on this graph, I think you can see that all the points are already scoring more than 300. And what that means is if something is 300, that means it's 3 times as high as the average or reference population. So what you can see from this graph is that from all the time points on the graph, the population aged under 75 with severe mental illness have mortality rates that are more than 3 times as high as the general population aged under 75. And over the time period of the graph, that situation has been getting progressively worse. So the most recent data point, it's 3.7 times as high. One of the things that's important to highlight at this point is that this graph only runs as far as 2014-15, and we need to be able to bring, currently we cannot update this data set. We're putting some work in to make sure that that situation changes. The other thing to say about this graph is this is looking at mortality overall in the population with SMI, and we are particularly interested in the physical health of people with SMI. Next slide, please. So this graph shows 4 major contributors to mortality in the population with severe mental illness. And hopefully what you can see, because it's exactly the same basis as the previous graph, where it's the comparison to 100, that for liver disease, respiratory disease, cardiovascular disease, and cancer, that all of these conditions, you see higher death rates in the population aged under 75 with SMI than the general population. And hopefully what you can see from this graph is that when you look at liver disease and respiratory disease, you're seeing rates that are almost 5 times as high. For cardiovascular disease, it's 3 times as high, and for cancer, it's almost twice as high. So you're seeing significantly higher rates for all of these conditions. Next slide, please. This graph presents the data slightly differently, and the point behind it is that sometimes you look at relative differences and sometimes you look at absolute differences. So this tries to show the mortality rate per 100,000 in the population, and you see that the bars on the left-hand side are the general population, and the bars on the right-hand side are the population with severe mental illness. And hopefully what you can see is that when you look at liver disease, you can see that those rates are 5 times as high in the population with SMI than the general population. But actually if you look at cardiovascular disease and cancer disease, that you don't see the relative difference being so great, i.e. they're not 5 times as high. But if you look at the overall numbers, you see that greater numbers of people are impacted upon. So from a population perspective, what you would want to do to maximize return is focus on interventions that reach the most people. And what it's important to say here is that this is a national picture, and the local picture will be somewhat similar, but not exactly the same. And it's important that that we review this data at a local level so that we know which areas we should focus on most of all. The other important thing to say here is that these bars are represent disease groups, not individual conditions. And the last thing to say about this this particular figure is that this is focusing on mortality. And if we want to make a difference, then we need to focus on and look and consider people who are living with the condition. So at this point, I'd like to hand over to Gabi, who will talk through the main report findings and will also give an indication of how we hope the report can be used locally.
Thank you, Cam. So what I would like to do over the next 20 minutes to describe you the methods we took to analyze physical health inequalities in people with SMI registered with general practice, summarize some of the main findings from the report, and as well to highlight to you how you could use our findings at local level. If we could go to the next slide, please. As we heard in the introductions, people with SMI experience a great inequality in the premature mortality, and we know as well that the level is increasing. To help us to understand and address this inequality, which leads to an average life expectancy of someone living with SMI today that's similar to life expectancy of an average adult in 1950s, we require a better understanding of physical health in people with SMI. And this is required to support the development of strategies, policies, guidance at national and local level, and as well to support development, planning, managing, provision of different services provided for people with SMI. And it is services that not only address the mental health needs, but as well at the same time the physical health needs. There is a large volume of research that looks at poor physical health in people with SMI, but there are only few large-scale studies that compare the prevalence of physical health conditions in people with SMI with general population. And many of the studies that were carried out in England focus on some specific conditions or focus on some specific areas of England. So our study is unique that looks at the whole of England, so it uses a sample of primary care data, and it looks at 10 different conditions, physical health conditions at the same time. So what we are aiming to achieve with the study is to increase our understanding of physical health conditions in people with SMI, to add to the intelligence around the health inequalities people with SMI experience compared to general population, and provide intelligence that allows the health and care system to focus on key areas for interventions and early preventions as well to reduce premature mortality among people with SMI as described in the introductions. So the way we approached it, we used a primary care data set, so a sample, and we compared the recorded prevalence of people with SMI in England by age, sex and deprivation, and then we look at the level of physical health conditions people with SMI experience and compare that with general population and look at differences by age, sex and deprivation. So what I would like to do now very briefly before we move on to the findings, to describe the methodology to you very briefly. So if we go to the next slide, please. So we will look at patient age 50 to 74 registered with general practice in England. So we used a sample of general practice database. So that sample was based on over 150 practices in England. That gave us a sample of over 1 million patients across England, aged 15 to 74. And of those patients, over 9,000 patients were diagnosed with SMI. So just to put that number in perspective, comparing to other national surveys, for example, the Adult Psychiatric Morbidity Survey, it's based on just over 7,000 people. So our sample is a large sample. Of course, it doesn't have the benefit of random sampling, but we compared the demographic breakdown of our population in that sample, and that compares very well with general practice population in England. And just to give you a very overall overview in terms of the level of physical inequalities in our SMI population, general population, for just over 40% of patients with SMI, we found physical health conditions, and that compares to just under 30% of patients, all patients in general practice. So what I would like to do now is just to highlight some of the main findings to you. So if we go to the next slide, please. So they are just highlight results from the report, and more detailed findings are can be found in the report, which there is a link at the end of the report as well, which you can access online. One thing to add here is that our report aimed to measure the level of inequality, and we don't provide answers on some of the causes for some of the inequalities. So it's really just a measure of inequality in people with SMI comparing to general population. So what I would like to start with is just to highlight how to use our charts. So the green bars present people with SMI. So it's the prevalence of physical health conditions in people with severe mental illness. The grey bars are all patients within general practice using the primary care data sets. The bars just above the green bars are confidence intervals, and they are providing us of level of estimations how accurate that estimate is of the general SMI population. The numbers above the green bars provide us a measure of inequality. So that's rate ratio, that's comparing a prevalence of physical health conditions of people in SMI comparing to all patients. So if we look at the bar chart here, what we can see here that generally people with SMI experience a higher level of physical health conditions, and the conditions where the prevalence was the highest was obesity, asthma, hypertension, and diabetes. For hypertension, for example, we didn't find that the prevalence was higher than the general population. So in our report, the prevalence was similar, but nevertheless, we can see that is a large burden in people with SMI. If we then look at the inequality, so that's the numbers above the green bars, we can see that the different level of inequality differs depending on the condition. So, for example, the greatest inequality is for COPD, diabetes, and obesity. So we can see that the prevalence for some of the highest conditions doesn't necessarily, it's not necessarily the same as for the inequality measures. So if we now go to the next slide, please. So one of the things we were interested to look is how some of the inequalities differ within the SMI sampled as well. So what this slide here looks at the breakdown of the physical health conditions by age. We also, as well, in the report, you can find similar findings by sex and by deprivation as well. As you can see here, we use a wider age group to look at physical health inequalities by ages. And the reason for that is that this allows us a big enough sample to make sure that some of our results are robust and are accurate. And we only focus on conditions where we could achieve the breakdown that provide us with sufficient sample. So what we're looking here is only on obesity, asthma, hypertension, and diabetes. So that's only 4 out of the 10 physical health conditions we examined. What I would like to highlight here is that comparing to the previous slides, we can see the younger people with SMI experience a greater level of inequality if we look at the whole cohort, 15 to 74. So what the slide indicates here is that some of the inequality that people with SMI experience starts much younger in life, and therefore people with SMI require different outreach strategies to provide some of the prevention and early interventions that are required to tackle some of the poor physical health issues. So, for example, if we look at obesity, people aged 15 to 34 with SMI are 3 times more likely to have a prevalence of obesity. If we look at all ages, that was around twice as likely. And as well for hypertension, where the difference was not statistically significant, for the younger age groups, we see that for 15 to 34, that's 3 times more likely. And for 35 to 54, it's again just over 1 times more likely to have that condition. We also find that people with SMI have multiple physical health conditions. And again, when compared to general population, the inequality is greater for younger ages. So if we move to the next slide, please. So this slide here looks at 3 or more physical health conditions and compares that comorbidity for people with SMI and all patients 15 to 74 in general practice. As we can see here, for females and male 15 to 74, that inequality is around 1.5 more likely to have multiple conditions. Again, if we look at different age groups, if we look at the younger age groups, that's 5 times as high for ages 50 to 34. So people with SMI not only experience a higher level of physical health inequalities at younger age groups, but will experience multiple physical health conditions as well. As we can see here, the deprivation breakdown, it's not very clear. It doesn't provide a clear trend. We know that people with SMI are more likely to live in more deprived areas, and our findings from our study confirm that. And if you look at our report on our website, there is a very clear gradient that people in more deprived areas are more likely to have the diagnosis of SMI. Some previous research suggested that living in more deprived areas and socioeconomic deprivations can explain partly some of the physical health inequalities people with SMI experience. So we accounted for that in our analysis. So if we could please move to the next slide. So what this slide does here is it's very similar to our first slide showing some of the results from our study. But the difference is here that it adjusts the prevalence for physical health conditions by age, sex, and deprivations. Some of the age groups we had to use for that adjustments are slightly wider than our 5 years age group. So some level of caution needs to be taken when using those results. But nevertheless, we can see here, if we adjust for age, sex, and deprivations, the physical health inequalities in people with SMI comparing to all patients still exist. So they are slightly lower, but they still exist, and they still are present for obesity, asthma, diabetes, COPD, CHD, and stroke. As highlighted right at the beginning of my presentations, our report only shows results at England level, so it's national level report. So how can you use the findings to your local areas? So what I would like to do now is just to take you through some examples how this report can be used at local level. So I will take you through 3 different approaches how that data can be used at local level, and all these 3 different approaches depend on different level access to data at your local level, different access to analytical and statistical support as well, and different levels of understanding of your local population. So the first scenario is where access to primary care local level data is available. So our technical supplement, which is published together with our data briefing, provides you with all the required information for you to be able to repeat that analysis at local level. And the link here is an active link, which takes you then to our report and provides you with that information. So our technical supplement includes all the information in terms of all exclusion and inclusion criteria, so defines the sample very clearly, provides with a comprehensive list of read codes that then can be used at your local level for the analysis. This will provide you with all the details on the statistical analysis that we applied. Some tables of results, very detailed tables of results that you can compare your results to the statistical analysis we carried out, and to be able to verify your local findings. Right at the end, it's access to some Public Health England's technical guidance, and that provides you with a number of templates where you can then enter your local data to be able to carry out some of the statistical analysis. Few things to highlight here, that your local level of access to data might differ to the structure of the primary care data we use. So it's very important that you work very closely with your clinical experts and with your data management experts as well to be able to account for the differences. At the same time, if you see findings that they are different and to the findings we reported in our report, it is very important that you validate the findings with your clinical colleagues and your service colleagues as well, and to make sure that your analysis reflects the true picture at local level. So we now move to the next slide, please. So this approach doesn't require access to record level primary care data, but it does require some input from analytical teams or statistical teams as well. So first, it's very important to understand your local population. So how does your local populations compares to the population we use in our study? The first bullet point provides you a link to patient registered practice populations, and from that you will be able to understand the age and breakdown and sex breakdown of your local population, and then you can compare it to the to our breakdown that's provided again in the technical supplement. Then it's very important that you get a better understanding of your SMI population. So of course the size of your SMI population you can get from your QOF register, and a larger QOF register will indicate that possibly your population is more deprived, but of course there's other factors that will account for that as well. The second bullet point provides you a link to a sample of primary care data that has been commissioned for people, health and care of people with learning disability. But the benefit of the data, it has some comparison sample cohorts, and that includes a SMI sample that will provide you for your local area, for example, for your CCG, and additional information on the age and sex structure of your SMI population. So using your OGP registered population and the sample of your SMI population, you can gain a better understanding of how your population at local level compares to the population we use in our study. So once you're satisfied that you have a good understanding of your local population, then using some of the estimates from our study, which again are provided in our technical supplements, then you're able to apply some of the prevalence estimates to your local population. And to be able to do that, you are required to break down your population by sex, age groups, and deprivations, and that's provide you in table 4 and 5 from our technical supplement. You will be able to estimate some prevalence of physical health conditions. So one word of caution is here that all our prevalence of physical health conditions are adjusted for age, sex, and deprivations as well. So if you have evidence that your local population differs in terms of age and sex structure, a level of caution is to be then applied to how you use your results. You will be able to calculate some age-specific prevalence for physical health conditions, and again, a table 6 in our technical supplement will provide you all the required information. And as well, look at some of the levels of comorbidities in your local population. So this approach here requires some analytical input and some statistical input as well. So if we go to the next slide, please. So how can you use our findings at local level if you just want to have a very quick overview of what do the findings from our report mean to your local population? So this scenario is very, very crude. It does rely on the assumptions that your population locally is very similar to our sample we use for our national study. And it estimates numbers at risk, so it estimates numbers at risk in your SMI populations of a population of 1,000. So if we just very briefly look at the top table, you can very clearly see that using our proportions from our national study, majority of your populations in SMI is expected to be between the ages 15 to 74. So therefore, the rest of the estimates are based on population 15 to 74. So if you assume an SMI population of 1,000 age 15 to 74, applying the prevalence from our national report, you can expect that 130 people in your local populations would be obese, who are diagnosed with SMI as well. 120 people would have asthma or hypertension. So they are, for each individual physical health conditions, 100 people would have diabetes, 30 people would have COPD, 20 people have cancer, CHD or stroke, and 10 have AF or heart failure. One thing to add here is that we know that some of the estimates are likely to be underestimating, so some of the levels of inequality is likely to be higher in your local populations as well. So in terms of comorbidities as well, applying some of the findings from our results, we can see that 410 people with SMI will have one or more physical health conditions at the same time as as diagnosis of SMI. And if we look at 3 or more physical health conditions at the same time as diagnosis of SMI, that would be around 50 people in your local populations. And the tables below provide you with a breakdown by the different age groups to allow you to identify some of the populations at risk where early interventions and early preventions could be then applied. So if we move to the next slide, please. So what's next? We can see that people with SMI experience a great level of physical health inequalities. So currently we are working on phase 2 of our work, using again the sample of primary care data, and we are looking at access to and uptake of cancer screening programs within SMI population compared to general populations. We'll be focusing on breast, cervical and bowel cancer screening. And as well, we will be looking at access to physical health checks and what happens next after a health check. So access to post-check interventions and any differences those interventions make. So that's a work we're currently working on, and hopefully we will be publishing that report in early summer this year. So in terms of understanding better your local population, I just would like to highlight some of our profiling tools through our fingertips platform, and especially the mental health and well-being GSNA tool, which helps you to understand the level of need for your local population, and of course the severe mental illness tool as well, which might be will be very helpful to help you to understand the level of needs and in your local population with severe mental illness. So that summarizes the findings and of the report and how we can use the report at local level. So I will hand over to Simran now.
Brilliant, thanks Gabi. I'll now hand over to Andy Bell and Hannah Lewis, who are going to give you an overview of the Equally Well UK initiative.
Hi, thank you. So I'm Andy Bell. I work at Centre for Mental Health. We're an independent charity that seeks to use research and evidence to drive change in policy and practice, and with a particular interest in reducing inequalities in mental health. And there are a few areas where there are starker and indeed more extraordinary inequalities in mental health than in the physical health and life expectancy of people who happen to be living with a mental health condition. As a result of that, working with our colleagues at Rethink and Kaleidoscope and indeed many of the Royal Colleges, we've set up something called Equally Well in the UK. It's about bringing together organisations to create a collaborative for equal health for people living with a severe mental illness. And there are really 3 important principles behind it. First is really that the only way we are going to make a change in some of the statistics that Cam and Gabi have already spoken about is by bringing organisations together across sectors. We really do need a whole system response to this. It requires public health, it requires primary care, we certainly need mental health services to do their part, but also acute and community services, training organisations, user-led organisations, charities. Everyone across the piece has some part to play in making a difference to this. We also know that we need to value personal and professional experience equally, and that's an area that Hannah's going to speak about particularly. And we know that there's a lot of knowledge out there, and that in almost all the things that we think need to be done to reduce this inequality are being done somewhere, but very often people don't know about it. So it's bringing together the wisdom of many organisations and many people working across the system to help to make a difference, and that's what we're all about. So during the course of the next year, we're going to be having events. We're going to be bringing people together in a learning network. We've produced a website which is already pulling together resources, and there'll be many, many more to come. We have a Twitter account, Equally Well UK, rather creatively, and the aim is really to make sure that people have access to the information they need and the ideas that might help them to make a change. In terms of what this report means to us, I think it is important to remain shocked in some ways by the data that's been displayed here. And I think really crucially, a lot of what's been said we've known for many, many years. We know about early mortality. We know that poor physical health is almost taken for granted among people living with a mental illness. And I think this is the opportunity to change that narrative and say actually it's not okay. And particularly that we need to act early in life. The starkest thing in this data is that the biggest inequalities are among younger adults. So we do need to get help in early. We do need to ensure that people start well, and we need to begin to make the changes to the way people are supported with their physical health from very early on. So I hope you want to join Equally Well. If you want to find out about it, do get in touch with us. Call me, email me, write to us, find us on Twitter, and do get in touch and do get involved. Together we really can make a difference. I'm now happy to hand over to Hannah to talk about Rethink's really important contribution to Equally Well.
Brilliant. Thank you, Andy. So, as Simran said, I'm Hannah and I'm from Rethink Mental Illness. And for those of you who don't know us, Rethink is a national charity and service provider seeking to help those who are severely affected by mental illness. And a big priority for us has always been to address this health inequality gap, which, as we know, leads to those with SMI living shorter lives by around 15 to 20 years. Now, as we know, the reasons for this have been outlined in the report, and they're obviously very, very complex. So we at Rethink Mental Illness, we strongly believe that solutions need to have the voices of those with lived experience at the fore. You know, we need a bottom-up approach here rather than a top-down one to really find the most appropriate answers in the most collaborative way. So with that in mind, it feels very appropriate that our role in Equally Well is to facilitate the co-production element and lead on the involvement of those with lived experience of both mental and physical health conditions. And we do this by running the Lived Experience Advisory Group, which runs in tandem with the Clinical Advisory Group, where we truly are bridging the gap between mental health research, policy and practice. Now, what really strikes me about this approach is how well it fits with addressing the issues raised in the report, because we really do need to look beyond telling patients to eat more fruit and veg and exercise, and we need to look at the wider determinants of poor mental and physical health. So it's for this reason I'm really looking forward to looking closer at the needs of local areas to understand the nuances of this broader issue of shortened life expectancy for those with SMI. And there's another thing from the report that really struck me, and it was how there was such a disparity between the younger age gap, which I think just really proves how we need to take a life course approach to these issues and examine how we can intervene at the earliest possible opportunity and really listen to the voices of those from the younger end of the scale and understand where we could have stepped in earlier in the past and where we can learn from missed opportunities to really improve the future for other people living with severe mental illness. And so I'm really looking forward to being a part of Equally Well and working with the members to find more viable solutions to the issues highlighted today, and of course ensure that the voices of those who have lived experience are at the forefront of this cause.
Brilliant. Thank you, Hannah. So that takes us to the end of this webinar. Just before I close, I just wanted to bring your attention to this final slide, which captures all our contact details and provides links to some of the key resources we've discussed on this webinar. Thank you for joining us. Thank you.